I'm Harvey Cohn, a pediatric oncologist and medical director of the Pediatric Palliative Care Program.
I'm Barbara Sirks. I'm a child psychologist and I am director of the Palliative Care Program.
And I'm Julie Good, a pediatrician and a pain management specialist and part of the palliative care team.
First, I wanted to talk about setting the stage. Oftentimes, fellows and attendings are asked to have care conferences with families, and I wanted to work through how we can effectively set up a care conference or a meeting with a family. Harvey, would you mind telling the fellows what we can do before the conference or before the meeting to prepare for that?
If the meeting is going to be a care conference, I think it's important for the team to meet together before the family meets with the team. I think we have to find a location that will work for the number of people who will be there and determine what our goals are for the conference and who will say what, and be sure that we have enough time to discuss all of these issues prior to calling the family in.
Going back to what I said about having a common message, that really is critical, and it comes out of the research that we've done with bereaved families looking back at their experience of palliative care. And they have told us that one of the biggest stressors for them were mixed messages, where one team said one thing, one said another, and they did not know where to put themselves. And that is why, even if there isn't total agreement among the team ahead of time, at least it's presented in a cohesive way to the family.
Well, in terms of the family members, I think it's really important for the family to decide who they think is important to be at that conference. Sometimes it's other members of the family, sometimes it's clergy, sometimes it's friends, and really let them know that it's really their conference too. So while we want to talk to them about the things that we think are important, we want to be sure that they are also able to discuss and have whoever they feel comfortable discussing it with them.
And we have to be prepared for some possible inconvenience. Often the critical family member can't come in until the evening, and it really is not fair to have a care conference with a lot of information and decision making in office hours when you really do need that other family member to be there.
Can you touch on setting up the goals for the conference and whose goals those should be, whether those should be the provider's goals or the family's goals, and how you broach that topic?
I think it has to be both goals. And the goal setting by the team should really happen in that pre-conference time. To say at the end of this conference, what do we want to have accomplished, whether it is information sharing, whether it's broaching an important decision that will have to be made, or whether it's hearing a decision from the family. So that really, again, has to be very cohesive. Families sometimes know well ahead of time what they want to say, and you know that before they come in the room. But whether you do or not, it's really a very open gesture to start with saying to the family, first of all, tell us how you think your child is doing today, anything that you particularly want us to know. And related to that very closely is, what do you hope to get out of the conference today? And you look to see what the match is, and if it's way off, you've got to accommodate the family's agenda as well as your own.
Often I will ask the family to write down questions before the conference, because sometimes it's hard in the middle of the conference to come up with all their questions, but the best conferences are one when the family actually has prepared what they think are important and gets those questions answered too.
That's such a good point too. Sometimes the patient is too sick to come to the meeting and they may have questions. Mm-hmm. So it's something I often ask too, when they're preparing for the conference, what would they want their family members to ask?
Feel free to ask for help before the conference happens. If you're feeling overwhelmed or you're unsure, whether it's about the medical information per se, or whether it's simply how to conduct it, ask a mentor, call the palliative care team. But prepare yourself in whatever way you need to. This does not have to be the ultimate test. You're allowed to have some help until you develop your own comfort and style.
So my name's Jim, and my daughter Jillian died of cardiomyopathy. And she was born with Down syndrome. And at her age of 1, she was diagnosed with myelodysplasia, a pre-leukemia situation. At about 18 months, she was diagnosed with full AML, leukemia. And she was then treated on a very 6-month aggressive treatment protocol for the leukemia. And she fared very well. Kids with Down syndrome typically fare very well with AML. However, about 3 months after her treatments were complete, she was diagnosed with congestive heart failure. So after she was diagnosed with congestive heart failure in the spring of 2000 and survived 3 weeks in ICU, she was put on a litany of heart meds to keep her alive. It was then about 10 months later we decided to come to Packard to see what else we could do to give her support for her heart. And the docs were able to put her on a medication that often adults are put on. So although it wasn't experimental, it was something new that's not typically done with kids. And that seemed to give her a lot of support. And so from the 2001 until the time that she died in 2008, she was able to live a decent life, although quite limited. With a child with heart failure, when I think of heart failure, when I heard the word congestive heart failure, I'm thinking of a grandparent who's laid in bed. And so her vitality and her ability to live through life was very limited in the sense of we had a homeschool teacher that came to take care of her. Any of our outings were very limited, whereas a typical family might go to the beach for a day, we'd go to the beach for 20 minutes. So even coming to our appointments at the hospital, those are very laborious for both her and us as a family. So a lot of intensive care for our daughter. Things, quickly developed towards the end of her life that she ended up dying of congestive heart failure. And we opted to go home, and she died at home after about a 3-month stay on hospice. What makes caring for a family feel like they're being cared for? Probably the biggest thing is to really get to know the family you're caring for.
Next, we'll talk about some basic communication principles that the fellows can use during their conversations with families. It would be helpful if you could tell us, after you've sat down in the room, you've introduced everyone, gone through the logistics, how to start framing the conversation and how to ask the family what they know and deliver the information that you want to get across. Harvey, could you comment on that?
Sure. I think we've begun to discuss it a little bit, but it's important, even though we have our agenda and what we think is important for the families to hear, I think it's critically important that the first thing we should ask the family is, one, how they feel the child is doing, and then what are the important questions for them that they'd like us to try to answer. Very often that'll help set the tone for the rest of the discussion.
What do you do if the family's goals for the conversation are very different than your own goals for the conversation?
So realize that this discussion is for both the family and the professionals. And I think it's important to address those even before you wind up addressing your own. Because if the family doesn't sense that we're listening to them and responding to them, it makes it much more difficult for them to both grasp and listen to what we're saying. So that's why I think the first thing we should do is find that out, because we have to address that before we get to our own goals.
And there's another aspect of hearing about how the child is doing and also what their goals are, and that is along the lines of jargon. Like, I notice sometimes when we start out and we just talk about the medical issues, we tend to talk at a level that we feel comfortable interacting with our peers in using that kind of language. And when you allow the family to first start off and describe their child, you get a sense of what kind of language they use about their child's illness.
I think an addendum to that is sometime when we have very educated families, we assume that we can use more jargon or more terminology. And I think what we have to remember is whatever the educational level, the intelligence level, when families are so vulnerable in such an emotional position dealing with their child, that's the universal, and that we have to be careful to bring our language to a common denominator level as a given, and then occasionally adjust it. But interestingly, I think sometimes we don't do our best with highly educated families who need the same simple message at that time to be able to absorb it.
We also have a tendency to speak for a long period of time during these conferences. And I think it's important during the conversation to stop periodically and ask if the family has some questions, not necessarily to go through everything you wanted to say first. And then it's also important at the end of the discussion, after we've said what we think is important, to find out what the family has actually heard. And sometimes we're surprised the differences between what we've said and what the families have told us they've heard. But unless we do that, I don't think we're going to know whether our message was actually received.
And it also allows us a point to naturally summarize. So, the family might do a nice job of summarizing for us, or we might then be able to realize that they've gotten lost in all the details. And it provides us a place of sort of summarizing and then maybe moving on to what action or options come from that.
And also in the discussion, I think it's important both to be honest and straightforward, but also listen and watch to what the family is responding to, and make some sort of mid-course corrections if you either sense that they're not understanding it or this is too disturbing for them at that time.
My name is Allie. We adopted our daughter Micah in November of 2005 from China. She was 11 months old at the time. 3 weeks after we adopted her, on her first birthday, she had a febrile seizure, which was just diagnosed as something simple, and we were given the precautions that we were supposed to take and things we were supposed to do if it happened again. A few months after that, Micah had a complex series of seizures where we came to Packard and we were here for a week. She had a full workup, and we left with a kind of unknown complex febrile seizures diagnosis. After that point, she was being followed by neurology, and a few months after that, Micah had another complex series of seizures. She was hospitalized here at Packard again. They decided, because her seizures were very difficult to control, to put her into a propofol coma. And it was our understanding at that point that she would be under the medication for a while, give her brain a chance to rest, and then they would let up the medication and we would see how she was doing and go from there. And so even though it was a very serious situation of her being in a medically induced coma, we had a lot of positive response from the doctors that things were going to be fine, and we just kind of had to wait through this. And a couple of days after we were given that information, there were some neurological signs that the doctors were seeing that her neurological activity had decreased, and she had a CAT scan which showed that she had really diffuse brain swelling. And about 24 hours after that, after having an evening and a day to have friends and family come and for us to hold Micah, we took her off of life support.
The family poses a question to you that you don't know the answer. It is really fine and appreciated by families if you say, I don't know how to answer that right now. Perhaps, and there may be someone in the room, or I will get that information for you and get back to you later or tomorrow. And the second important thing is to keep that promise. you say you're going to come back with the information, come back with it. But don't be afraid of saying, I don't know, because nobody knows everything. And families really appreciate honesty. That's really basic.
And if maybe we're not understanding what the family is saying, to ask to tell us more about it. What did this really mean to you, or what do you mean by this, and how does it affect your situation? So I think it's important to sometimes bring out more from the family than what they initially say.
Yeah, like an example of when they saw their child like that, or what they noticed and what concerned them.
One of the most startling things for me was that how things changed quickly and how surprised the doctors were at how quickly things changed. So everybody went from, this is serious, but okay, we're going to manage this, she's going to be on anti-seizure medication, to, we're very sorry, but there's no brain activity. So it was a very quick turnaround. We had a lot of, having surprise from the doctors was unsettling, I think, especially for me, because I wanted to instill all of this confidence and knowledge, and I saw it was difficult for them as well to not have answers for us. Why did this happen? How did this change so quickly? When did it change? And for them not to have answers was really difficult. But I did appreciate their honesty during that time.
Take your time, slow down. If the parents are very emotional and overwhelmed, they're not going to hear the information until you have, at the very least, asked them whether they want to tell you what has triggered the tears, for example, or simply for you to say, I can only imagine how hard this is to be at this kind of conference about your child. It's hard for every parent. We give you the information, we are not in your shoes. Tell us how we can present it to you. And the acknowledgement is very important. It doesn't have to be deeply psychological, but it's very respectful to say, we see the distress, we think we might understand it, but tell us what's going on.
Yes, often you can give them permission to talk about it by saying that when this information is given to families, it often produces some real emotional aspects to it. Just by letting them know that they're not abnormal by feeling this can actually allow them to discuss it. And I think you're absolutely right. We shouldn't deny that, nor should we try to get past it. I think we need to deal with that, because if we don't also deal with the emotional aspects, we're not going to be able to get the information through in the best possible way.
I think when we're focused on being an expert in an area, the first thing we need to remember when a family is expressing emotion is that we're also human. And so some of the first things I do are I kind of have to get out of my head and I have to say, kind of stop and embody, just be there, because just by even being there and allowing silence to start can be so helpful and acknowledging and supportive. As if we were doing that for a friend in just that moment. And then asking the question and wanting to know more can be very helpful.
I think one reason we rush through is that the parents' pain is very painful for us. And I think all of us, and especially in beginning this kind of work, because I've heard it so repetitively, the biggest fear is, what if the parents see me tear up? What if I cry? What if I show that emotion? And the fact is, and again, there's documentation, families appreciate seeing that tear. They will not appreciate if you take up their entire space by some massive reaction, but when they see that you are truly moved, that you are truly distressed, they take it for what it is, which is that you really, really care about their child. And I know it's true for me, but I think everybody, that those first few years, you try and be just kind of rigid in case some emotion seeps out, when in fact, as you said, Julie, it's an ultimate human encounter, and the best you can be is be human, respectful of their space, but human.
It's true, and recognize the fact that it is normal for you to feel bad for yourself, Because yes, it's maybe a terrible discussion that you have to do with terrible issues you have to deal with the family, but so they're suffering, but you're suffering too because you have to deliver that news. And almost giving yourself permission to feel bad for yourself is okay, because I think once you do that, you can then feel bad for others.
I think body language is important at the moment when a family expresses emotion, and to the extent that you can lean in or be interested in the emotion just as you are in other things they might express. So not crossing, backing away, standing up, that kind of thing. It can be helpful, even just to, leaning in. And sometimes touch.
Yeah.
I think sometimes, a hand on the arm or.
It should be what you're comfortable with. I think if you're not comfortable touching, then I don't think
Yeah.
it's good, because people will sense it. And it's also important to feel how the person's responding to that too, because often people really feel very close if you touch them or put your arm around them. But some people, they don't want it, and it's important for you to sense that too. But often you're right, the non-language activities are equally as important or more important than the language.
Are there other phrases that you would recommend using when a fellow sees that perhaps a family has a lot of emotional response to something, whether that's angry, sad, upset, and phrases that you would specifically recommend not using?
One that I think can help is by giving permission, by saying that it's really a normal reaction, or other families react this way. One that isn't always helpful is saying, I understand what you're feeling, because it's really hard to understand what a family is going through.
Sometimes actually taking that sort of one down by saying, I can't even begin to imagine what you're feeling, but other parents have told me, and then name it that way. So they hear it from other parents, and you have excluded yourself from that.
In some older models of palliative care, there was more of a definitive cure-directed therapy and then a transition to palliative care. And it seems like a newer model is to have concurrent care throughout a patient's entire disease process. Harvey, can you speak a little bit on that and when palliative care should be involved?
Yes, I think you said it correctly. In the past, it was an either or. Either you got disease-related treatment or you got palliative treatment. And the model now has really evolved to a point where one should think about doing both at the same time. And clearly there are times in the course of the treating a child or a family that there's going to be more emphasis on one versus the other. But for children who have life-limiting or life-threatening illnesses, one should consider palliative care early on in their treatment and early on in their disease. And getting a consult or getting the palliative care team involved earlier rather than later can be very helpful for a number of reasons. One is we can start establishing relationships with the family early on, and then so when things happen and things may not be working so well, at least we're familiar to the family. The other is that there's no reason why we couldn't address symptoms and other things that the families worry about at the same time as we're addressing the disease and its treatment. So the model that seems to work well is if you think there might be a place for palliative care, either in terms of decision-making, symptom relief, helping siblings of children who are having these life-threatening illnesses, then consider a consultation at that point.
What doesn't work historically or in the present is when palliative care is called in at a very, very late stage of the child's illness, and instinctively, both professionals and the parents say, uh-oh, the palliative care team is here, this must be very bad, this must be the end. Which is one reason that introducing the concepts earlier, even if it's not the team, is important. And we found that it's been a major educational undertaking over 10 years for people to not instinctively think, oh, palliative care means hospice care means end-of-life care. but rather to say how we see palliative care is a very comprehensive spectrum of which the end-of-life care is just one small slice. That comment comes out of the assumption, mistaken, but understandable traditionally, that the family is not ready to hear that palliative care is coming because you mean end of life and death and dying. And so when we hear the family isn't ready, that's first of all the assumption of the person who said it, that that's what we represent exclusively. And that's important both in terms of they're trying to protect the family from us descending and giving that message, but it's hard, particularly if it's the attending physician. Also, if that is their concept of palliative care, it's difficult to say, okay, I'm handing the family over to you. And that is where it's so important to have the broader view of things. Because when we have found, and it's taken patience and time and education, when people understand how broad palliative care interventions can be, you hear less and less of it's too early, because people realize that there's a lot of value added.
For certain children with certain diseases, palliative care is part of their treatment right from the diagnosis. So for certain genetic diseases where you know there's not going to be a cure, at least not what we know of right now, in addition to treating the children with those diseases in terms of what the diseases manifest themselves as, it's also important to know that these families are going to often have to make decisions as what's best for their child, and often deal with symptoms that occur as a result of these diseases. So getting us involved right from the beginning is actually quite helpful. The other issue is for neonates who've had an event when they were born, in which they may not have further events, but that event will cause other problems during the course of their life. And again, it's an area where having the palliative care team involved as part of the teams that are taking care of these children and families can be very helpful to the families.
I think one way I look at it too is like we're going in a depth, like we're peeling layers off, and one of those, the layers that we're peeling off is the hopes, to understand each layer of the hopes. That on the outside, we hope for cure, but then families have other hopes, and so shedding a light or uncovering those other hopes can be so important. And then the other thing I was thinking about as you both spoke too is that we want to get involved with the teams and be seen as part of the treating team, and that we're not going to take over, that we are going to be involved and work with and coordinate is so important.
Even when there is concurrent palliative care, there are clear time points during the course of a patient's illness where there is deterioration or events that happen. And we may be at a place where we feel like further disease-related therapy or curative-related therapy is going to do more harm than good. When we want to discuss other options, how can we broach those conversations and bring that up in a respectful way to the family?
I think that a phrase that we have learned from a nurse who originally said it, but has been extraordinarily helpful for parents, is to talk to them about thinking about when they are doing something for their child and when they're doing something to their child. Families want to do for their child, and it's a difficult balance. Sometimes we feel they're doing to and the family still feels for. But I'd say without exception, when we present that to the families, that we want you to think about that, and we're thinking about when you're doing for your child versus to your child, it is usually a light bulb, and it really helps people clarify a direction right then and there.
Yeah, often they haven't thought about that because they've sort of been told along the line, as usual, this is happening, therefore we're going to do this, and then this is happening, we'll do that. But there are sometimes the question is it really in my child's interest to do this? And also sometimes to think about that when you're making those decisions, what's in their child's interest and what's in their interest, because often families have their own views of what they need.
Have we reached a point where this is so much? Because I have other options, things that I can do if we shift the emphasis and focus and really put to the top of the list a child's comfort.
Often the treating team gets to the point of seeing the futility, as it's said, of further disease-related treatment before the family does. And so we often present our ideas and our recommendations based on that. And it's not always as rapid for the family to get to the same point. So I think one of the things that we have to realize is that when we think there may be nothing more that can be done to treat the child's disease, the family may not be ready for that. So this is probably one of the most difficult conversations for not just fellows, but for any physician to go through, in part because it recognizes our own failure, that we really feel bad for the fact that we tried something and it didn't work. And so we have to be able to acknowledge that part. But in part because we also still want to be able to help the family, and we recognize that what's going to help the family most is not necessarily another treatment for their disease, but some comfort for their child and for them. And I think it is important when we have come to that point to be able to say that what we feel is best for that child, that we've known this child and this family for this long, we've fought the fight with them in terms of trying to reverse disease processes, cure diseases, and it's not going to work anymore, but we still want to be there for them and their family. And we feel at this point the best we can offer is to make the child as comfortable as possible, to give them as much good time as possible, to give the family as much good time as they can have, but to use comfort as the overarching aspect of the care that we're going to give. And I think that still shows that we're caregivers, that we're not taking care of them. It's not either we give this treatment or we do nothing. It's never do nothing. It's we've changing to the goal of care being cure or prolongation of life to comfort and quality of life. And it's as much of a care as any other part. And as difficult as it is, it's also probably the time where we as caregivers are most effective in terms of who we are, because it means that we will be there with the family. We will not abandon them, we will not abandon their child, and we will respond to the issues that they and their children face, and we will be walking that journey with them.
I think in terms of language, sometimes jumping from disease-related, we've been doing all these, to comfort is jarring, because it's exactly what the parents have feared, that we're going to go aggressively for a disease and then it's just going to be comfort. And sometime a transition, and this term is being used more as palliative treatment, not palliative care. That up till now you've done disease-related treatments, and we're now going to think in terms of palliative treatments. And so it keeps something level. It's a different direction, but it's not that sense sometimes that people have that we really are doing nothing. And so I think sometimes using palliative treatment, which is real, is a good introduction, a good transition phrase for the family. And then one of the palliative treatments, obviously, is keeping your child comfortable. It also may be getting your child back to school. There may be many different ones, but palliative treatments can be a very powerful help in that transition.
I think so important in this is that position of non-abandonment, that we're not going to give you over to a completely different team now, because that feels also very jarring, that we're going to continue with the same intensity that we had in managing and trying to cure, and still hold out hope that there might be something or a miracle. A lot of families feel like they want to hold out hope for that miracle and not have that squashed, but that we are still going to be here and we're going to shift our work, so we'll still be all engaged in this. I think that matters so much. One thing you always say to Harvey is you owe them a recommendation. You know, I think that's so important too, that we don't offer a menu of options and leave it all up to the family, right? We lean in a direction, or we offer a suggestion, but also say that we'll support other viable options.
I think that's something we're, I think, getting a little bit better at, which is getting away from the menu option and just saying, what do you want us to do, to making the recommendation. And it's not always easy to do because often the recommendation is to not do any more disease-related treatment. And when we do that, we sometimes have a hard time adjusting to the fact that the family may not agree that that's the best to do. But as you said, the thing that we have to realize is that we need to support the family whatever decision they make. I think it's helpful to the family if we give the recommendation, because often it's easier for them to say, if that's what you suggest, that's what we'll do, rather than having to pick that decision themselves. But it's equally courageous for the family to say, no, I think we still need to do another option. And it's really at that point our role to, in fact, do what that family wants to do. But at the same time, I think it's also our obligation to make sure that the child suffers as little as possible while these other treatments are being done.
I think it's also a time I go to the bedside and I really try to understand from the family's perspective what meaning that child has. Just because we're not seeing the same level of interaction or an interaction that we would want or we would expect from the child. Children have roles in families, and getting to really know that and to be willing to come there and see the value that child's life has in a family can help us, I guess, feel a little softer around that hard. It feels like futility feels so hard and finite to me.
Yeah, we often talk about quality of life and that we don't think the child's life has quality. And I think sometimes going and looking or listening to what that child's life is like for that family often changes our minds. Because it's not really the quality of life as we see it, but the quality of life as the family sees it.
As the family lives it,
And lives
not
it.
just sees it.
Barbara, you mentioned getting at goals a little bit when you mentioned school. How can we as a fellow help to figure out what the family's goals are and listen to their goals and then respond with a recommendation that matches their goals?
I think it relates to what Julie said earlier about definitions of hope. Going into these illnesses, families have exactly one hope, which is their child will be cured and live 90 years. And that is their definition of hope. And the biggest modification may be many years, if not cure. So for them to even imagine there are other things to be hopeful for, there could be goals, is a whole new way of thinking. And that's something often that in discussions we have to say. We have to say, you've had hopes for the cure, and we are all disappointed we couldn't do that. Let's think about other hopes for your child. And, whether it's the trip or whether it's getting back to school, which it is for many children, or whether it's getting a grandparent to visit. But it's a shifting of that definition, because up to that point, hope has been associated only with cure and quantity of life. And I think that very often, once you help the parents broaden their definition of hope, families come up with what their hopes would be.
Well, and study after study shows that pain and symptoms are very prominent. 60 to 80% of patients with CF, with cancer, with neurologic diseases at the end of life suffer multiple symptoms, and they suffer them too. It's not just that they have them, but that we didn't adequately manage them. So we have lots of work to do.
And so there are things that we can do and offer a family other than treating their disease.
Yeah.
I think a related point is, again, this comes from one of our parents who said, always leave a glimmer of hope. I think that when we present this bad news to families and the parents come back and say, well, I just know my child's going to live. I know my child's going to be the 1/10 of 1%. And often we're so anxious hearing that. It's like, oh my God, they didn't get any of the message, they're denying. And so you sort of pound it into them. And there really is no need to. Let families say that. Let families say that, because things happen, things don't happen, but let them go through the rest of the life with whatever glimmer they need. The only reason to take away a glimmer is if they're doing something that would be damaging for their child. But if it's keeping that glimmer, whether it's religious, spiritual, just hope, 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 it only can help them get through an excruciating period, and we don't need to correct them.
My name's Nancy Ross, and my son Patrick was treated here at Stanford at the Children's Hospital. He was 20 years old, just about to turn 21, and he was having a lot of pain. I took him to the emergency room, and he was diagnosed with cancer, a very rare cancer called desmoplastic small round blue cell tumor. And they were pretty clear with us right from the very beginning that he wasn't going to get better from this cancer. But he took it as a challenge and thought, I'm going to be the one who beats it. The good thing for him was, even though he was big and almost an adult, he was treated at the Children's Hospital because it's a pediatric cancer. That was the biggest blessing for him, because at the Children's Hospital, they pay attention to the kids. They're used to people who are in parental mode, and they're used to having scared kids. Patrick was both a grown-up and a scared kid, and he was also a sight to behold at the Children's Hospital. He was 6'1", 200 pounds. He wore black t-shirts. He was tattooed and pierced and had crazy hair. He wasn't what they were used to seeing. So nurses and doctors would come in to see him for the first time with their little tiny stethoscopes, and they'd take one look and say, okay, I'll be right back. Their job, I felt, was to make Patrick feel safe and to make him feel seen. And that's what they did. They came in and they took care of him. He had radiation, he had chemotherapy, he was immune to almost every pain medication there was, and the pain team, they were his buddies. They were on it, they were with him, they tried things I'd never heard of, things that everyone has tried. People were with him right through it. He was afraid, and he wanted to make an impression. And so people who took time with him and paid attention to him were giving him the best care that he needed. And toward the end of his life, it was really terrible, because the pain medication, it didn't really work for him. We had him on hospice, but they couldn't handle him. He couldn't breathe. The morphine wasn't helping, even though they said, more, it'll be okay. It wasn't. He was in bad shape. He was scared. We brought him back to the hospital. And this is where he died. My son Pat has a sister, Kelsey, and she's 2 years younger than he is. So she was in college when he got sick. And she came home from college to be with him because he really just wanted her there. She was his partner in crime. She played with him. She was at the hospital with him a lot of the time. Her experience was that she was invisible. That when the residents came in, when the doctors came in, the nurses came in, they would address Pat's dad, Jim, they would address me, and she would just be standing there. And they would ask things about Patrick, and he would answer, but he was scared. Sometimes he would look to me, and I'd say, well, he's felt like this, and he's felt like that. And at the end of the day, she would say, he tells me things too. I know things, that could be helpful. No one ever even looks at me. So I would say it's a really important thing. My daughter happened to be practically an adult herself, so someone who really could participate. But even a child who's younger is probably going to know things about the sick kid that none of the adults are privy to. And even if it's not valuable medical information, it's important to make them part of the process.
So often the fellow is asked to, quote, get the DNI order signed by the parents, when in fact the parents don't sign a DNI. Actually the physician signs it, but it's after a discussion with the parents. And it often happens that the question is not only should this child be resuscitated or intubated, but importantly, what is the appropriate care for this child at this time in terms of other kinds of interventions. So really the idea of a resuscitation and intubation has to be seen in the context of what are the appropriate interventions for this child at this time. And I think it's a discussion that often happens when the therapeutic options in terms of the disease are gone, or when the condition has deteriorated to where people feel that something can happen, untoward can happen pretty soon. And so the reason we're asking is, in a sense, we want to know what to do if these events occur. And I think one of the things that's been helpful for us in terms of discussing all of these with the family is to think of it, what are the therapeutic options and what are the therapeutic the wishes. And to even just use the word, do you want your child resuscitated? It's sort of hard to think about anyone who would not want to have a child resuscitated. And we often use the word, in a sense, do you want attempts made at resuscitation? And then to explain what that would mean, because it's only a word. So what does that mean when you're saying we're going to attempt to resuscitate? What does that mean? And I think it needs to be described in terms that families can understand what might happen if the child's heart were to stop, what would be done to try to intervene in terms of both medications, chest compressions, electrical stimulations. Those are things that might be tried. And also in terms of intubation, what that might mean to put a tube in. I think it's important to distinguish intubation for the short term versus intubation for the long term, so that if the intubation needs are due to the disease processes that are felt to be irreversible, then one is talking about intubation without extubation. But there are times when even in a child who's going to die of their disease, an untoward event could occur and they may require intubation for a short period of time. So I think there too, discussion should occur in terms of what one means when one is deciding not to or to intubate a child. And then when talking about these options, one also has to think about other interventions that may or may not be appropriate, such as treating infections, treating metabolic conditions and the like. And the whole, all aspects of this treatment are really dealt with in a sense with a form called the PULSed form, which is Physician's Orders for Life-Sustaining Treatment. And they talk about these kinds of interventions, including the use of artificial nutrition or fluids. And truly, we use those words, artificial nutrition, rather than food, because if someone wanted food, we would feed them, but whether or not it's appropriate for this child in this situation to add artificial nutrition. And the same thing with fluids. We're not talking about drinking, we're talking about adding fluids artificially, and whether that's appropriate, whether it's in terms of intravenous or NG or G-tube mediated nutrition or fluids. So I think those are all parts of the discussion. And often we come with our recommendations, and I think that is important, that we either recommend or don't recommend certain things based on what we know about that child and the family. But we really also have to be prepared for the fact that the family may not agree to that suggestion. And it's a very appropriate and reasonable decision for the family to say, no, they're not ready to not attempt resuscitations or not do intubations.
Beginning the conversation with, I have, some things I need to discuss with you that you don't need to make a decision right now about. It's interesting that when that is said, oftentimes it frees up the family to make a decision in that time. And then approaching it as a conversation related to both the goals of care, kind of starting with where we're at with the medical management in general, and then couching the different decisions in how they would help support the goals of care or not support the goals of care.
The other is to not continue to badger the families, because often we want them to agree to these recommendations, and so if they don't do it one week, we ask them again and again. And I think we have to be a little bit more respectful of that decision, and once we've asked that, maybe wait for in a time, either because if there's a change in the status, so it requires another discussion, that's one thing, but otherwise wait for some clues from the family before bringing it up again.
Go ahead.
I was just going to say that an important understanding that people need is that even if you implement the DNR, DNI, families have told us they're afraid to do that because they're afraid if the child's chart has DNR, DNI, it means we've given up and we're not going to do anything else. And they've actually given us some painful examples of one child, a very neurologically devastated child, where the mother had asked that the DNR, DNI be put in place, and the child developed an infection and was being wheeled down to the PICU, and someone said, why would you take him to the PICU? He has a DNR in place. So it's very important for the fellows themselves to remember the DNR, DNI refers to a specific intervention. It does not necessarily refer to the whole picture, and to make sure the families understand that too.
The other thing is to think about the outcomes from intubation, for example. So if it's, we have a disease process that's ongoing and intubation occurs, were to occur, kind of to walk the family through, okay, then what does that look like and what would the treatment options be at that point? Or what are all of the active things we can do when we're not intubating? Because I think families worry that, my child's gonna have end of life, die feeling like they're suffocating. No, we have, active interventions that we would implement at that point. What does it feel like? They may want to know, what does it feel like to die with your blood pressure dropping? What if we didn't do that? I think to the best that you can, explain what it looks like to a family as well as what it feels like to the child and what you're going to do to help ease that process. Can then give them more equal choices than just, oh, we're gonna do this or we're not.
How you respond to this is actually in part determined by your senses about yourself. And I've been asked that question a number of times, and it's never been easy. I can't give glib answers because it's not the situation for glib answers. But the first thing I do usually say is, I don't know. Because I don't know, because I've not been in that situation. So I don't know how I would respond, and that is the truth. On the other hand, I don't think that's always helpful enough, because they're, in a sense, are asking, what would you do? But really, in your heart of heart, what do you really recommend? And so my approach has been that I would go to someone I really trusted as a physician and ask them what they think is best for my child. Not what they think is best for the disease or what they think is best for a phenomenon that's going on, but knowing me and knowing my child, what would you recommend?
And the people who were upfront with us and helped to be clearest with us about what was going on with him were the most helpful.
When a family asks, how long is my child going to live? What is this going to look like? What can we expect? How should we answer those questions when we're not sure of the prognosis, when we're not sure how long they're going to live? We don't necessarily have the right answer.
So what you're saying is absolutely true. We don't know. That is the truth. I don't think we're that good at prognosticating the time of death. We can just maybe be better at knowing whether it's going to be a short time or a long time, and I think it's important that we're, despite the fact that we don't know, give people our best estimate, but know that it's just an estimate, but that they need to be prepared. If we think that it could possibly happen within the next days or weeks, then we need to let them know that so they can be prepared for that, but to be equally prepared for the fact that it may not occur for weeks to months, and that to be prepared for that. So I think it's important for people to hear both what we know and what we don't know, and what the range of our prognosis is.
Don't be afraid to tell us, because that's the other thing we really needed to know. What do you think is happening here? You, unfortunately, are watching young people die. Lots and lots of times. This is hopefully our only time we're going to see this happen. If I ask you, could this go on for 2 weeks? And you know it's not going to take 2 weeks. Could you please say yes? I know you can't pinpoint when it's going to happen, and that somebody can always surprise you. But when we're looking for ballparks of things to help us cope and you have some knowledge that's way more than ours. Please don't be afraid to say it. We're looking for guidance as we go through it.
Consistently, the research shows that physicians' prognostications are not accurate. The generalities are generalities, but it's the science of it isn't there yet. And that can help the fellow who says, I don't know, by saying it's something we haven't achieved yet in our field, so I will give you a global estimate. The other thing that's important for fellows to know, it doesn't necessarily come into discussion, is that a child who dies much faster than you predicted is of course traumatic. A child who way outlives what you predicted is very difficult in another way. Families may feel guilty admitting that, but there's a time factor of preparation, and when the shoe doesn't fall off the other foot, it can create a great deal of stress for a family. And so you really do want to get that estimate word in as much as possible so that families don't absolutely focus on something.
Living people are in the process of dying, so these children are still alive, so they should still continue to plan for things, even though they may not get to all those plans. But if you stop planning, if you stop doing things that are important to you, then you've essentially had the death occur sooner than it really has happened. So I've often say, keep planning, just know that you may not get to all of those, but don't stop planning.
The interesting part is that transition was absolutely abysmal. And that's one of the things I think medicine today needs to fix, especially a child, because there's such a limited population of these kids moving from acute care to hospice care. It's not like the adult world where there's large demographics we can look at and large population studies we can do, but with kids there's only a few of these. For me, I was very naive. We had moved into hospice care and I didn't like the nurse, I didn't like the way it was going, I fired my nurse, but when I talked to my nurse practitioner from my acute care team, she made it very simple to me. She goes, Jim, there's just not a lot of nurses with this specificity that you're looking for a child who's an oncology patient and a congestive heart failure. You're not going to find a lot of pediatric palliative care nurses that are working for hospice organizations that have this kind of experience. So it dawned on me then that I was a very small data point on a bigger picture. The problem with that is because that transition didn't go well, it was just terrible. From a parent's perspective, you're thinking about acute care, but getting your mind wrapped around the fact that this is no longer acute care, this is just taking care of your child and letting them die with the celebration that they came into life with when they were born. And once I wrapped my mind around that, things were easier. But the reality is the transition didn't happen well. So there needs to be a better way of making sure that when a child's ready to go home to hospice, all the T's are crossed, all the I's are dotted, the game plan is made.
Sometimes the most important person is the case manager. And first we try to find out from the family what is it that they want. Do they want the child to be at home in a different place? Do they want certain interventions to be made at home or not at home? And we've stopped promising because we don't know what's going to be available in any one community. But we work very closely with our case managers to see what actually can be done to allow these wishes to occur. And at the same time, we actually prepare the families to know that sometimes, despite what they want, it may not be successful, and to not necessarily look at having to come back to the hospital as being a failure, that's something they shouldn't have tried, because sometimes things happen that really require hospitalization even towards the end of life. But even if the attempt is made, whether it's successful or not, at least we can say, you tried.
I think that raises a related point, which is with the upsurge of palliative care. There have been some judgments in place which are not helpful. One being that dying in the hospital is not what you would want. Of course you would want to die at home. And families sometimes pick that up and feel very self-conscious in saying, we don't want to go home, we're frightened, we feel secure here, we want our child to die here. So we have to be very careful to keep our own judgments out of the way, and we have often no sense of what home means or looks like or is, and to really explain the options, the reversibility, that you choose one, you may decide to change it. But the value judgment has been there in the last, I'd say, decade or so about the assumption that you want your child to die at home, when in fact, for a myriad of reasons, many families do not.
I think what's hard in talking to such a diverse group of fellows is to sort of remember some basic things. First of all is the difficulty of assessment, especially in nonverbal patients, and that what a patient is offering in terms of a severity score is only one aspect. We want to kind of get curious and get to know lots more about the pain. And so when we're talking with families or even beginning that conversation with a patient, to ask a lot of questions, to find out where it's located, does it radiate, what makes it better or worse, timing, get a sense in a daily fashion, how much of the day are they suffering? How does this impact their quality of life? How does it impact the goals, the things that they want to do on a day-to-day basis? And for a lot of diseases, opiates are, in a lot of pain processes, opiates are going to be your mainstay. And families have a lot of questions about opiates. They have a lot of silent concerns that you need to kind of draw out and bring up. They may worry that your offering of opiates means this is the end of life. We've had patients where they have had a grandparent die and opiates were not offered until the end of life. So does this mean my child is dying because you're offering opiates? So normalizing it in the context of disease. Preemptively giving medications when we know we're going to cause pain with a treatment can be helpful kind of signposts along the way where they've known and seen opiates be used. In standard management, we do increases, so we start with baseline doses, and those can be found in house step manuals and online, and all those calculators. And so we make changes of 10 to 20% of the dose that we're using if we're managing uncontrolled pain, not at end of life. But it is not uncommon to use doses that are 50 to 100% changes, especially if we're seeing some response with opiates. And then you mentioned adjuvants. We're always on the pain service thinking in a multidisciplinary management way. And so thinking about what drugs are possible to be used that are non-opiate adjuvants can be as simple as Tylenol, acetaminophen, or ibuprofen. Or if it's neuropathic pain that's not going to be as responsive to opiates, to have ones that you're using and learning to titrate while you're a fellow so that you feel really comfortable out of training in using some of those medications. And addressing proactively when you feel the hesitation, or even just a family's not using what you've asked them, you've prescribed. What are their worries about using opiates? How are you going to manage? Tell them how you're going to manage the side effects. What comes along with giving good pain management? Sometimes there's going to be side effects, and how we're going to do that. Always prescribe medication for constipation when you're giving regular opiates. They'll worry unnecessarily about addiction. Addiction is very rare in patients with complex chronic disease, but diversion does happen, and so you're going to monitor and be closely watching the medication use and be concerned when a child is medicating psychological symptoms. You want to be able to provide expert management of other symptoms. And then tell them ahead of time about tolerance, or as it's happening, that it's normal for the doses to go up. It doesn't mean the disease is worsening. It's just a normal response. Our bodies, in seeing the opiates, just like steroids, get kind of used to them. And so we wouldn't suddenly take them away. That would cause withdrawal. It would cause problems if you did that with steroids too. And then it's a normal process for the dose to need to increase. It's called tolerance, and it's just the receptors changing, and we're going to be able to still effectively manage pain later. It's just that the milligram or the microgram dose will change.
You mentioned a little bit about the receptors changing and about tolerance. Can you comment on opioid rotation a little bit for fellows?
Sure. So I usually base decisions to opiate rotate on unacceptable side effects. Although there is the special situation, especially with like fentanyl infusions, where we call something acute tolerance or tachyphylaxis, and we're going up and not seeing the pain response we want. What we notice with other opiates is that we're running into unacceptable side effects, either sedation or itching or nausea. And so we can use an opioid conversion table, and we can convert to a new opiate, and because the receptors are triggered a little bit differently, lower the dose for incomplete cross tolerance. And what we do as a pain service is we have more than one of us calculating that. We're using opioid calculators and those conversion tables, and we independently figure out the dose and then discuss it together, because you can reduce some for incomplete cross tolerance and sometimes get rid of side effects, oftentimes get rid of side effects, and also better control the pain.
You mentioned supportive care medicines for people who are on opioids, constipation medicines. Are there other things that fellows should make sure that they're prescribing to take care of the patient as a whole when we're prescribing lots of pain medicines?
It depends on if it's inpatient or outpatient basis. If you're just initiating on an outpatient basis, I think you should consider other common side effects of opiates, like sedation that doesn't get better on a stable dose after a couple of days, itching, and nausea as a reason to change to a new opiate. If you're inpatient and you're initiating someone in a pain crisis, or you're in one of the ICUs, you should just assume when you start a PCA or a drip that there's going to be nausea and itching, and preemptively order PRNs for those nurses to have available. And that's on a lot of standard order sets. Develop your favorites for that. Interestingly, we don't tend to see a lot of nausea or itch in babies, so we might not use those as frequently in babies.
How do you recommend that we can support our residents through these difficult situations?
I think some of it is going to come from your own experience of managing the pain. I can feel very confident as a pain specialist, having made changes of 100% over and over again, that even though we talk about the principle of double effect and wanting to manage the pain, and we will allow the consequence of a shortened life or respiratory compromise or that kind of thing, honestly, if we're managing refractory pain at end of life, I've never been able to shorten a patient's life by providing those 50 to 100% changes, acknowledging that I'm paying attention to half-life and making appropriate bolus doses whenever I'm changing, so that we reach reach the new steady state. And you'll experience that as a fellow over time, and can provide that, that these are palliative principles, this is what's taught, and then you've done it and you've experienced that. Can help the resident feel like, okay, this makes sense. I think also calling on, if you have the ability to contact a pain specialist, especially during training, to do it, that we don't mind kind of calculating along with you and figuring out what we would do to help that patient. So helping the resident feel supported, I think, is really important.
Yeah, I think finding out what's making the resident uncomfortable is important, and then to try both acknowledge it, and then if you have the expertise, let them know that may or may not be a reason to feel uncomfortable. And I think you're absolutely right about the double effect that a lot of people talk about, which in kids who've been on pain medications for a long time, it's almost impossible to actually get. We've had children who go up to hundreds of milligrams of morphine, and that would, certainly stop us from breathing, but have no effect on their respiratory effort. Sometimes we would like that to be even a primary effect, because there's respiratory distress, but even there it may be sometimes hard to just with a drug that's used for pain to get that kind of an effect.
I also think acknowledging their distress, like if what they're really worried about is giving the last dose, or they're with the nurse who's afraid of giving the last dose, to remind them that this process is happening anyway, and that what you're there for is to help ease this end of life process for the child. And if we are not courageous and don't act, then a child dies in pain. That, you know, their death still is going to occur, but we're there and with the purpose of easing that time.
And just know that sometimes they really need you.
He was dying. When people are dying, give them what they need. Don't be afraid. Don't be afraid that it might happen on your watch. Don't understand that we know that this child is dying. Do the best that you can do and don't be afraid of it.
So I think it's really important for young doctors especially to be humble enough to realize that these parents know their kids inside and out. You have the professional tools, but it's a team that works together that's going to save and help these children. You may not save them, they may die, but if you're going to cure them, you know, you're going to cure them together as a team.
So one of the things that I've noticed in discussions is the fellows talk too much, and maybe not listen as much. And I think some of that comes out of our anxiety. And we feel like we've got to let the families know that we know what's happening, that we understand things. So maybe a little bit less talking and more listening.
Not reassessing, and also not acknowledging that families have a perspective, and that so much of pain management is around communicating and collaborating. It's not your pain. And so what we need to know is how their experience of pain, and this family member, parent who is feeling like this is the one thing they should be able to protect their child from is pain. And it's such a difficult thing to stand by and watch and not have any tools. So to the extent that we can involve child life specialists, psychology, physical therapy, nursing, occupational therapy, massage therapists, in helping the family figure out active ways that they can provide comfort, it can be so important in having people feel like I made a difference and I knew how to help and I had tools to help.
I think this is more conceptual, but I think people really do forget that there's a gamut of symptoms and focus so exclusively on pain sometime when nausea or seizures or psychological symptoms like depression, anxiety, all fall under symptom management and all can have a big impact on quality of life. And, you know, to put those under the rubric of symptoms can be very important in terms of making sure that you really are addressing the total care of the child.
The other thing is that it's sometimes easier to prevent pain than to treat pain. And we often wait for pain to occur and then we treat it, when in fact, when we know the disease process is going to produce pain, why don't we just work on preventing it? And I think the same thing is true for other symptoms too, that we treat anxiety and we treat depression and we treat these other psychic symptoms, but perhaps there are things that we can do to anticipate them.
So I experienced a very stark and noticeable difference in the traffic in Micah's room from before her CAT scan and after her CAT scan, or even the day that she was going to have the CAT scan, because of course the doctors had a sense of what was going on, and then they had to find time for her to get into the CAT scan. So during that time, before that, we had people in and out. We had people looking at the EEG. We had medication changes and all of these types of things. And the day that I walked in the morning from where I was sleeping, something felt different in the room. And that entire day, it was like a ghost town in our room. There were very few people in and out, and very few doctors coming to see us. So we had neurology following us and the PICU fellow, and there were lots of different physicians who were seeing us, and I barely saw any of them. And I had this sense that I wanted to go out and find people, but it was a situation I was really conflicted conflicted about because I wanted to stay with my daughter. I didn't want to leave the room. And so I felt very desperate, very alone. And frankly, I felt abandoned. Like, what, to have that knowledge in your gut that something is wrong, and to not have any outside mirroring for that, or any outside kind of someone validating what you're feeling and what you're going through, but just to be left there was really hard. So Elizabeth Edwards, who had a child who died, I think when he was a teenager, said something along the lines of, when you speak our child's name and talk of them, you don't remind us that they died, you remind us that they lived. And that's very true.